All right, I'm doing a review of some things I've learned in cardio so far. And I'm going to be covering some of the things too. You'll see. Okay, so here we go. So, first of all, hypertension. What is hypertension? Basically, what it means is that your blood pressure, or the pressure of the fluid inside of your vessels, is high. And this can really come about by two basic ways. Either your container can be too small, which means your vessels can be constricted, or you can have too much fluid in the container. And that's kind of the way you get high pressure in anything, right? So this just makes sense. Or it can be both. So there's systolic blood pressure and there's diastolic blood pressure. And what this basically means is when the heart pumps, when it kind of contracts down, they call that systole or systolic. And when it is relaxed, like filling full of blood, they call that diastolic, okay, or diastole. So the systolic blood pressure is how much pressure there is in your blood vessels when your heart is contracting, and diastolic means how much pressure there is on your blood vessels when the heart is not contracting, okay? So systolic blood pressure has a little bit more to do with the pressure during a heart squeeze, so it has a little bit more to do with cardiac output. So for example, some types of blood pressure have an isolated systolic blood pressure. For example, hyperthyroidism has an isolated systolic blood pressure, which means the blood pressure is high, the first number is high, the systolic blood pressure is high, but the second one might be normal. And there are other conditions where there might be a diastolic blood pressure that's elevated, so or both. So that is the first part here. So when do you start screening for hypertension? Well, you start around age 18 is when you should start, if not sooner. But that's what the book said. And then you should be checking it at least every 2 years. And blood pressure isn't considered, the person isn't considered to have hypertension unless their blood pressure exceeds 140/90. Now, if they're over 60 years old, it's such a common thing to have blood pressure that's higher than that they don't even really call it a disease anymore. They don't call it hypertension unless it's over 150, okay? So 140/90 for less than 60 years old and 150 for over 60 years old, okay? So let's talk about some types of hypertension here. Now, first of all is what they call essential hypertension, and that's basically 95% of all hypertension is essential hypertension. Is the kind of thing we were talking about earlier, where they've got the container's too small, or the blood vessels are too constricted, one of those two things or both, and they have hypertension. But there's also something called secondary hypertension, and this is basically if you can find any cause whatsoever for their hypertension, then they call that secondary hypertension. But usually they branch out into four general categories: renal, cardiovascular, endocrine, or drug-induced. And then, of course, there's some other ones too that kind of fit other ones. So let's go through these first. So let's start with renal. Okay, so renal, what I'm talking about here is the kidneys. And if you look in the kidneys, there is this thing up here in the top right. This is a glomerulus, and there's blood vessel that comes in called the afferent. Comes in here, and it strains, and then it goes out through the efferent. Okay, so afferent, A for approach and E for exit. So A approaches and E exits. And there are some, medications that will, for example, ACE inhibitors, where their bradykinin seems to have this effect of making the efferent arteriole larger, and so there's less pressure in this loop. We'll talk about some of these things as we go through. But this is kind of what's going on here. Glomerular disease is where a person basically has, you see there's protein coming through, and they usually have proteinuria, which means the protein's going through, this into the Bowman space, and they're urinating out this urine, and there's some sort of disease going on here that's making their blood pressure elevated. Why? Because they can't get rid of the fluid. If the fluid can't go here, they can't pee it out. Next is renal artery stenosis. And so you see here this afferent arteriole approaches, this glomerulus. Well, all these afferent arterioles are supplied by the renal artery, and the renal artery is what supplies the whole kidney with blood to be filtered. And sometimes this artery can become stenosed. Okay, it can be stenosis in an old man, usually with arterial sclerosis, like it shows here in this little picture. And then young women will sometimes get something called fibromuscular dysplasia, where it just kind of gets weird. These little bubbles there constricts the blood flow to it. And when that happens is that the kidney thinks, oh my gosh, I am not getting enough blood to the juxtaglomerular apparatus, which is this little group of cells. I'm not getting enough blood there. It's detecting that. And so it says, oh, okay, we're not getting enough blood. That means we must need more fluid. So that means we should act as if we're bleeding out or we're dehydrated or something. We need to hold on to fluid. So do everything you can to hold on to fluid. So the body holds on to all the fluid, and up goes the blood pressure. So it's not actually the case, though, right? I mean, the person isn't really out of fluid in their body. What's really just happening is it's not getting to the kidneys. There could be tons of fluid in the body, but if the kidney can't get it, the kidney doesn't know, and if the kidney doesn't know, then the kidney will act appropriately to what it thinks is going on, even though if it's not really what's going on. So those are instances that can cause elevated blood pressure. Another one, of course, is polycystic kidney disease. Another thing, clearly same kind of thing. Kidneys are messed up. Okay, next one here. So we went to the renal causes of secondary hypertension. Now we're going to the cardiovascular causes of secondary hypertension. One of them is called coarctation of the aorta. And this one's kind of funny because you see this aorta here, and there's these three vessels coming over the top. Okay, where do these blood vessels go? Well, they go to the head and they go to the arms, okay? And then down here, after this little squeeze tight portion of hair, this goes down to the legs. And so what you'll find is you'll check the blood pressure in somebody, and they will have really high blood pressure in their arms, but you'll check the blood pressure in their legs, and it will be really low. Why? Well, look at the anatomy. It's really obvious when you see why, because it gets pinched off right there. Okay, so that's called coarctation of the aorta. Now, the other one that can happen is something called aortic regurgitation. Okay, now this one's a weird one. Basically, you have these valves, okay, in your heart, and these valves, the one in the aorta, closes during diastole, okay, and then during systole, it's pushed open as the blood goes out through it. But what would happen if this valve was kind of screwed up? It couldn't do its job right, so it allowed blood to flow back into the heart again that it just came out of. Well, then the heart would try really hard to push it even harder out, and then it came back again. So it'd try even harder and the heart would just get really, really muscular and try really hard to get the blood through this out into the aorta and to the rest of the body, but it kept coming back in again. And the heart trying so hard for such a long time would cause some hypertrophy of the left ventricle, but also it would cause elevated blood pressure. And one thing you'd see especially is called the wide pulse pressure. Okay, so you'd see the pulse, the pressure on the pulse would be really would be wide, and be lengthened out. Okay, and so what are some things you'd find in that? You'd find a blowing early diastolic murmur at the aorta. And let me explain why this is. So during diastole is when the heart is relaxing, right? So blood goes out great during systole, squeezes it really hard, but during diastole, it's going and squeezing back through this valve that has it doesn't close all the way. So it's regurgitating back into the ventricle. And so you would hear the blowing sound during diastole while the ventricle is relaxed and filling full of blood again. So it's coming from the other way, from the atria, but instead it's coming back through the aorta. So you'd hear that, you know, at the aorta or the left sternal border. And there also could be an Austin Flint murmur, which is, again, apical and diastolic murmur. You'd hear a mid-systolic flow murmur sometimes, you know, as it's getting pushed across through that valve sometimes. And you'd have perhaps a laterally displaced point of maximal impulse, which means basically that down here in this corner where the left ventricle is would become so enlarged that the point of maximal impulse would be pushed off to the sides, would be displaced. Or you might even have a pulsus bispheriens, I hope I'm saying that right, which is the double-peaked arterial pulse. It's just from the same thing that's occurring. And what can cause this? Endocarditis, rheumatic fever, ventricular septal defect, that would be congenital, to congenital bicuspid aorta, tertiary syphilis, aortic dissection, Marfan syndrome, and trauma. Well, let's go through those in a little bit more detail and explain how this could happen. Okay, so you got to realize here, see this anatomy over here on the side, these papillary muscles. Okay, these little muscles here hold the valve in place, and the valve looks kind of like this. See, this is a tricuspid valve, and this is a bicuspid valve. Now, this valve here is supposed to be tricuspid, and then it's held in place with these papillary muscles. But what would happen if you had inflammation inside of your heart from Staph aureus, which is the one that really eats away at this, or group A strep, and you got these little vegetations on here? They would weaken the attachments of these papillary muscles, and so they wouldn't be able to hold this valve in place appropriately to keep the blood on the other side of the aorta and not back into the left ventricle. So both rheumatic heart disease and endocarditis can weaken this here and rupture these and allow the blood to come back again. Another thing that can do this is ventricular septal defect, which can happen in children. Or it could be from a congenital bicuspid aorta. And what basically happens here is, as you get older, your blood vessels, your valves do calcify in most people. And apparently the bicuspid valves, when they calcify, are more likely to be regurgitant than the tricuspid ones. So if a certain percentage of the population has a bicuspid one, which means it's more likely to calcify, which means it's more likely to regurgitate, it just isn't as good. Okay, and then tertiary syphilis is another cause. Syphilis, there's primary syphilis, where you have that painless ulcer, large hard ulcer on your genital, and some bilateral inguinal adenopathy. And then 48 weeks later, it can turn, if you don't get it treated with penicillin, it can turn into fever, lymphadenopathy, macupapular rash on the palms and soles, and condyloma lata. And then if it's still not treated, then perhaps even years later, unless it can go latent, sometime later, the person will start getting all these other problems. And tertiary syphilis is just devastating. It can go in the brain and make you crazy. It can have gummas, these little pockets of yucky death of all over your body. And some of these gummas can end up in your heart around these valves, and it can cause the issue of aortic regurgitation if they get messed up. And also remember, there's Arjo Robertson pupil, which is another sign of tertiary syphilis, is when people where they have they do have the accommodation reflex, but they do not have the pupillary reflex. Okay, so and you notice that ARP and PRA go backward. Accommodation reflex present, pupillary reflex absent. So PRA and ARP. Anyway, cool little thing there. Okay, so now what else can cause it? Aortic dissection. That's where basically this inner layer rips open and then blood collects on the other side. If this happens, it can also happen right around the valve, which can cause it to then not be able to close appropriately and regurgitation would occur. And then a Marfan syndrome, which is also associated with this, is basically just their heart's so dilated, they can get so dilated from dilated cardiomyopathy that it doesn't meet together appropriately, and the blood can come back through again. And then, of course, trauma. A person's in a terrible accident and it rips it open. That can happen too. So let's talk about the next causes here, which are endocrine causes of hypertension. And with these ones, there are two basic ones we look at, which is Cone syndrome and Cushing syndrome. So first of all, Cone syndrome, this is the more simple, straightforward one. Basically what happens is you have something called aldosterone, which is released into your body, and aldosterone promotes your kidneys to, in those glomerulus, basically to hold on to salt. And since salt has a basically a potential to hold on to water, it retains the water with it. So it pulls the water with it because of those osmotic pressures. So aldosterone is like kind of aldosterone. You think of salt kind of like a stone. It holds on to the salt. Okay, and with the salt, it holds on to the water. And what happens? Well, if somebody has Cone syndrome, they have hyperplasia, basically adrenal cortical adenoma that could occur here, which means they're massively producing all this aldosterone. There are, I believe, also the other conditions similar to this, but basically more salt and water and less potassium. and that'll be some of the signs of Cone syndrome along with hypertension. And what about Cushing syndrome? Well, basically, Cushing syndrome is where the person has too much cortisol, and this could be either them taking it exogenously or endogenously, which means they could be doing a pill or it could be coming from their adrenal glands. And even from their adrenal glands, you could be wondering, well, is it coming from there because it's being triggered from the brain, or is it coming from there because it is, just being secreted from there primarily? So you can look at. There's a lot of different ways of testing this. Typically, they'll do like a dexamethasone suppression test. Low dose first, and they'll try a high dose. They'll do usually first they'll do a overnight or 24-hour urine test to see what the levels of cortisol are, and but typically these are pretty easy to catch in a STEM in a question, because they'll talk about the moon face and the red cheeks and the acne and the thin skin and the buffalo hump and the poor wound healing and the red striations all over their body. Pretty straightforward. And then usually central obesity as well, something they'll usually point out, which I don't see on there. So yeah, that's another one. And the cortisol has a number of different effects that also result in hypertension. So, all right, what about drugs? Drugs can also cause hypertension. So let's go through some of them. We have oral contraceptives. And basically, if there's a woman that's over 35 and she's smoking, you don't give her oral contraceptives because of blood coagulation problems that can occur there. She can become hypercoagulable. But if a girl has hypertension and she's taking oral contraceptives, then you need to assume that perhaps that is what is causing it, that it's drug-induced hypertension, and you should try stopping the oral contraceptives to see if it resolves. Another one, phenylephrine, NSAIDs, cocaine, and I just want to take a moment here to look at cocaine. You remember cocaine has the dilated pupils. I kind of think of this little rim around the edge of the eye kind of looking like a C. See how thin it is? It's like a C around the edge, and it's because it's all dark and filled in with a black in the middle. That helps you remember that's mydriasis, which is the dilated pupils happen with cocaine, C for cocaine. The runny nose from snorting, nosebleeds from snorting. They've got track marks from injecting it, or maybe they burned lips or fingers from smoking it. They have a fast heart rate, constricted blood vessels, and heck, that's probably why they have hypertension. Enlarged heart attacks, cardiac arrest. Mental state, they're going to feel euphoric, overconfident, unusually excited, aggressive, paranoid, poor judgment, be delusional, and maybe even be having hallucinations. And then also, of course, there's amphetamines, which would be things such as methylphenidate, or which is Ritalin. There's different drugs that can be associated with that. And then also alcohol withdrawal. Remember, alcohol is a depressive medication, and when people stop taking it for a while, let's say they go in for a surgery or something, and their body goes through with alcohol withdrawal, it can, because it's adapted to being in that sort of depressed state, it can actually cause super excitement to occur, because it's kind of finding the new normal, and during that excitement period, hyperexcitability, they can get hypertension, and they get shakes, and they can get something called delirium tremens, which basically they go crazy, and they can actually die. So you need to be really careful if you need to catch this before it starts happening. Usually it'll be sometimes within a few hours to a day or so, and you'll start seeing some of these symptoms. And if that's the case, you need to give them benzodiazepines and then kind of taper them off slowly. Another thing that can cause it, are these some of these older drugs like monoamine oxidase inhibitors, but even the new ones too. If you can get serotonin syndrome if you overdose on these, or if you take them with another medication that also does the same thing. And if someone's having serotonin syndrome, you can help them with nitroprusside or esmolol, but do not give them propranolol. Okay. So now next here, other things that can randomly just cause this: hyperthyroidism. Okay. Now in this case, hyperthyroidism, you do want to give propranolol. Okay. Especially for the acute, like the thyroid storm. But beta blockers are good. Why? Because hyperthyroidism is basically just everything's ramped up. So their heart is ramped up. It's pushing really hard. So you'll find that isolated systolic blood pressure. And with the isolated systolic blood pressure, you can just basically take a beta blocker, which calms the heart down, makes it go slower, not contract quite as hard, and helps relieve some of those symptoms. And just a couple different things with hyperthyroidism. Remember Graves' disease? Graves' disease is where the person has antibodies to the TSH receptors in the thyroid gland, and so basically they act to stimulate the thyroid, and the person gets the pretibial myxedema. You see it on their shins, and they get those big bulging eyes. It's very typical of that. And then another thing that can cause this is a functioning adenoma, toxic multinodular goiter. Those can get really big, hot nodules, pumping out T3, T4. Another one that can do it, of course, is excessive intake of thyroid hormones. Levothyroxine, take a bunch of that. This will do it. Or sometimes the person can have a thyroid-stimulating hormone secreting from their anterior pituitary, and that can also go down and stimulate to happen. Maybe it's a tumor or something. But sometimes it's just right there on the thyroid itself. The thyroid can get inflamed. And there's two here. I want to be sure that you do not get them confused. De Quervain's subacute granulomatous thyroiditis is basically a viral infection that's happening in your thyroid. And so you need to be aware that that when a person has a viral infection in their thyroid, that can cause increased amounts of release of T3, T4. Do not get that confused with Hashimoto's thyroiditis, which is basically you get antibodies that attack your thyroid, and this is it's antimicrosomal or antithyroglobulin. I believe that's what they were. Hopefully, I'm not getting those confused. Maybe double check that one. But that does not cause hyperthyroidism. That causes hypothyroidism. So make sure you get that straight. And of course, excessive iodine intake can do this as well. Another thing that can cause it is something called a pheochromocytoma. This is basically where they get neuroendocrine tumor Kolchitsky cells that are releasing too much norepinephrine. Normally you'd want to get these out, but you got to make sure that you give them alpha blockers first, because otherwise they can have basically a rebound of it, and it can be bad. So you need to kind of like prep them before the surgery so that they don't have a crisis afterwards. And then if they can't have surgery for some reason, whatever reason, maybe a bleeding disorder or something, or maybe they're really sick, then you can give them phenoxybenzamine or phentolamine, which block the effect of those. So what about pregnancy and hypertension? Because this can be a really big issue. Sometimes pregnancy-associated complications can cause hypertension. And there's a few here that I want to talk about associated with pregnancy and hypertension. And there's something called hypertension of pregnancy, and this is contrasted to pregnancy-induced hypertension. So hypertension of pregnancy just basically means this person has hypertension and they have pregnancy, okay? So this is when they have hypertension before 20 weeks. It could be they could have had hypertension before they were ever even pregnant, but it's sometime before 20 weeks. And if they have hypertension any time before 20 weeks, then they have pregnancy of hypertension. They do not have pregnancy-induced hypertension. Pregnancy-induced hypertension is when they got hypertension after 20 weeks. I said got hypertension after the first 20 weeks. So if it happens afterwards, then it's called pregnancy-induced hypertension, and before is hypertension of pregnancy. Get that straight, because they're treated differently. Okay, you typically think of methyl dopa is given if it's before, and afterwards is, I should say, hypertension of pregnancy is methyl dopa, and pregnancy-induced hypertension is hydralazine. Now, this is kind of hard to remember which one's which. So I try to think here, okay, mom gets pregnant, she gets full of water. Okay, so hydralazine, hydro, kind of sounds like water. So you think, oh, then afterwards, pregnancy-induced, hydro caused it, so I'll give her some hydralazine. That doesn't make logical sense. It's just a way for me to be able to remember the differences there. And the book I was reading, it was actually saying that the first thing you want to do with hypertension of pregnancy is to give labetalol. And if that doesn't work after 30 minutes, then you can just start giving methyl dopa. And I'll go into the method of action of these drugs after a little bit. So, all right, next one is preeclampsia. So preeclampsia is basically hypertension plus proteinuria. And if a person has hypertension plus proteinuria, you want to treat the hypertension and give them bed rest. And if it starts getting serious, hypertension starts getting really high, you need to probably have this baby as quickly as possible, because the only real cure for this is to deliver the baby. There are other things you can do, like giving magnesium sulfate or, things like that. But basically, the real cure here is going to be to deliver that baby. And there's something else associated with these a lot of times called HELP syndrome, HELLP, and it basically HELP stands for H for hemolysis, okay, so blood lysis, breakdown of red blood cells, EL for elevated liver enzymes, and so liver function, and then LP stands for low platelets. So if you see a combination of hemolysis, elevated liver enzymes, and low platelets, then you would say this person has HELP syndrome. Okay, so look for that. A pregnant lady with these 3 signs there, HELP syndrome. What do you need to do? You might need to transfuse some blood because their blood's breaking down. You might need to give them some platelets. You might have to give them some fresh frozen plasma or some IV fluids, maybe some pressors to maintain the blood pressure. But basically, the real treatment is going to be delivering the baby. Okay, so next here is essential hypertension. And this is, again, or as I said earlier, this is 95%. We've talked through all the secondary causes now, all of the weird things that can cause hypertension. And now we have arrived to the regular old essential hypertension. Now, what do we do to treat it? Well, first of all, we need to know that essential hypertension, even if it isn't caused by some secondary cause, is broken up into basically 4 different categories. There's the ordinary essential hypertension, and then there's something they call urgent hypertension or hypertensive urgency. Okay, there's urgent, there's emergent, and there's malignant. Kind of 3 levels there. So 170 over 100. 210 over 150 or 130 if they've got risks, like let's say, previous MI or congestive heart failure or maybe, diabetes or something, coronary artery disease, something like that. But basically higher than urgent. And then there is malignant. Now, oddly enough, malignant doesn't have a specific number associated with it. All that malignant means is hypertension that is causing end organ damage. Okay? So if it's causing end organ damage, we call it malignant. It is killing this person, okay? So, oliguria, which means not very much pee, with elevated creatinine, that can be evidence of it's damaging the kidneys. That's too much blood pressure there. BUN, proteinuria, hematuria, mental status change, headache, nausea, vomiting, seizures, focal neurological deficits, papilledema, pulmonary edema, chest pain, jugular venous distension, microangiopathic hemolytic anemia. All these things are evidences of that the blood pressure is so high it is killing things. Things are dying. Bad stuff. Okay, so urgent. What do we do for that? Well, this is urgent. We need to get it down. So, but it can be done over a few days. We don't need to go crazy here. But enalapril, and if you can't give them enalapril, maybe maybe they get angioedema when they take an enalapril or something. Then you can give them clonidine. Okay. Emergent hypertension. This is the more serious one. 210 over 150 or 130 if there's risks. For this one, you got to hospitalize this patient. This is a hypertension of an emergency, and they need to be admitted. And then you need to give them nitroprusside or labetalol to really try to get this down. But you need to be careful, though, because if you drop it too fast, then see the brain, the blood vessels, everything kind of adjust to how high the blood pressure is. And if you do things too fast in the body, then the person's the blood vessels in the body aren't going to have time to adapt appropriately, especially in the brain. And if you drop it more than 1/4, where it needs to be in 1 hour, which is a big drop, then the person might have a stroke. So you need to be careful. They were not going to get sufficient blood to their brain, and they could die from a stroke when you're trying to drop their blood pressure too fast. So be careful. Monitor it carefully with nitroprusside and labetalol. Make sure you don't drop it too fast. What about malignant hypertension or end organ damage? Okay, so in this case, first of all, you need to, if you're suspecting this, you're like, papilledema, chest vein, jugular venous distension, you're seeing these kind of things, then you need to think, all right, I got to do chest X-ray, got to do an EKG, got to do CT of the head. Now, why are you doing EKG? You're looking to see if there's any heart damage going on there. You could see the ST elevation or ST depression. Why a chest X-ray? That could help you find, pulmonary edema, that sort of thing. Why CT of the head? Well, you could find a brain bleed if that's occurring from the too much pressure. And then a basic metabolic panel, a complete blood count, urine analysis, and a urine drug screen to see if maybe they've overdosed on some drug. And what is the treatment? Well, of course, you need to hospitalize this person and give them IV nitroprusside or nitroglycerin. And apparently nitroglycerin is usually preferred if the person wouldn't be able to withstand rebound hypertension. Okay, so now we're moving on to essential hypertensive treatment. Okay, so now we've gone over the the urgency, and we've gone over the emergency, and we've gone over the malignancy of hypertension. We're now just plain old, the basic first thing we probably should have covered at the very beginning. We got all the other little rabbit holes out of the way. Now we're getting to the main one here. And what do you do to treat it? Well, first of all, you need to be thinking prevention, okay? Like there's something called the DASH diet. Basically, it means a diet that we're trying to lower their blood pressure through eating, okay, and activity. And there's an acronym it stands for, and I had to memorize it a moment ago, and I just forgot it. So anyway, low sodium, low fat, low alcohol, which means like 1 drink if you're a girl, maybe 2 drinks if you're a boy, okay? So low sodium, low fat, low alcohol, and high potassium food, high calcium food, plant food, which means fruits and veggies, and French fries does not count on there. And you should be taking a 30-minute walk daily, brisk walk, and you try to get your BMI somewhere between like 19 and 25, okay? But below 25 is usually, people be lucky if they get that, but don't get anorexic, of course. Okay, so what do you give if somebody has, blood pressure, hypertension, excuse me, and they, the DASH diet just didn't work. They did it for a while and there was no luck, okay? It wasn't keeping it down, it keeps going up. Well, now it's time to use something called a thiazide diuretic, okay? That's first line for everybody, thiazide diuretic. Now, there's a difference here that with studies they found that black people respond differently than white people to medication. If you're black, you don't give an ACE inhibitor next. But if you're white, you do give an ACE inhibitor next. Black people get calcium channel blockers next, like amlodipine, diltiazem, nicardipine, ifedipine, verapamil. Whereas whites will get ACE inhibitor like enalapril or one of the pril ending drugs, okay? Captopril, there's a bunch of them. So that's first line. Now, what if they have benign prostatic hyperplasia? So they're waking up multiple times in the middle of the night to pee. You know, you do a rectal exam, and you feel their rectal prostate exam, and you feel this enlarged, boggy prostate. Well, then you can give the person a alpha receptor blocker like terazosin or prazosin, and that can actually help treat both their blood pressure and their BPH. What if the person has hyperthyroidism? Well, then first line you're going to give them a beta blocker. Remember, propranolol was good for the thyroid storm. So next, first line chronic kidney disease. Well, if they got chronic kidney disease, remember that it's the ACE inhibitors that do a pretty good job because of the bradykinin. It basically stops an enzyme that breaks that down, and so you're able to have higher levels of bradykinin, which is a vasodilator, and that vasodilator is going to help to dilate the efferent arteriole on the glomerulus, which allows the blood to come in and go out. It's like a giant exit door of a building, so lots of people can get out really fast. And what does that do? Well, it puts less pressure in the blood vessel that's inside the glomerulus, and so less of it feels like it has to get strained through the glomerulus, which helps preserve some kidney function, actually, so their kidney doesn't get overworked. It decreases the workload on the kidney. So that can be a good thing. So if they've got, if it's too severe, then, you might shy away from it. But if they've got some chronic kidney disease, it might be helpful there. You can do an ACE or an ARB for that. An ACE stands for angiotensin converting enzyme inhibitor. I'll go into more of the stuff of that later. ARB stands for angiotensin receptor blocker. So first line for myocardial infarction. Now remember, myocardial infarction is where part of this person's heart has died. Now we're not talking about treating the MI. We're talking about treating a person who's had an MI in the past, and currently they have hypertension. Okay, so currently a person in the past, a long time ago, whatever, had an MI, now they've got hypertension. And you're going to use a beta blocker and ACE inhibitor. Why? Because they've done a study and they've shown that the people live longer when you do that. But it actually makes sense. Think about it. The beta blocker, what does it do? It slows down and relaxes the heart a little bit, so the heart isn't having to work super hard, and it helps retain some of the heart function. And then ACE inhibitors help to prevent remodeling of the heart. Sometimes they can remodel. It can cause really bad problems. You can get heart blocks and that sort of thing. So next here is first line. Remember, for pregnancy, if it's greater than 20 weeks, hydralazine, and so that'd be pregnancy-induced hypertension. And then hypertension of pregnancy, of course, you use labetalol or methyl-dopa. And second line for a white person is the ACE inhibitors I mentioned earlier. And second line for a black person, you use a calcium channel blocker like I mentioned earlier. And then third line, you can start looking at things like potassium sparing diuretics like spironolactone. Basically what that is it inhibits the effects of aldosterone. Okay. All right, so let's talk a little bit about some of the method of action of some of these drugs. So first of all, let's talk about these thiazides, these thiazide diuretics. So they're actually indapamide and metolazone are not actually thiazide, but they're thiazide-like, so they're kind of in the similar category because they do a similar thing. What they do is in the kidneys you have, coming out of here, out of the Bowman space, it goes into this long tubule, and it has a proximal portion, and it has a little loop of Henle. I should have drawn this out. And then it has a distal convoluted tubule, okay? And so this convoluted tubule, the distal portion is supposed to be where sodium is reabsorbed and water is reabsorbed back into the body. And what this does is thiazide diuretics prevent, in the distal convoluted tubule, the sodium and water reuptake. So basically, it makes you dump out sodium, and with the sodium, it gets dumped out water. And for some reason also stops, though, it prevents you from dumping out calcium. Probably has to do with an exchanger in there. It usually keeps track of positive and negative ions. It lets some go one and some of the other stay. And so in this equation, that's probably somewhat complex, calcium is retained. And then you think about that, well, that's good. That's good for osteoporosis. We don't want to pee out our calcium. We want to hold on to it. So in a postmenopausal woman, you're going to be thinking, thiazide diuretic is good because it's going to hold on to some calcium for this person so that it'll help with their osteoporosis. It has some sulfa allergy effects, and people have sulfa allergy, so it might be relatively contraindicated with them. It is contraindicated with diabetes mellitus. They've done some studies with that, and they found that basically, when sugar is taken into your cells, or I guess when insulin's effect is underway, the whole process, the transferring of these molecules, allowing the sugar to go into your cell, it involves potassium. Okay, and so this effect is somehow messed up with this, and basically what it does is, I believe that you actually lose potassium. Maybe double check this if I'm wrong, but this is my understanding. And because of that, because they're losing potassium, they're losing some of the effect of the insulin, and that promotes hyperglycemia, because if the sugar is not going into your cells, where is it going? Well, it's just going to chill out in the blood. If it chills out in the blood, the person's going to get worse effects of diabetes mellitus, and when you go to check a hemoglobin A1C, it's going to be elevated, and the person's going to be suffering from the damages, the tissue, the non-enzymatic glycosylation that occurs in the blood vessels that damages those. So not good. Don't use thiazide diuretics with diabetics, okay? Next one here, it's also contraindicated with gout, and this has to do with kind of a complicated thing. There's an exchange where basically you're going to pee out some uric acid, but instead you're peeing out the sodium, and so it holds on to some of the uric acid. The uric acid is collected in the body, and then it gets all collected down in your first toe joint there, and the person gets podagra, has terrible, painful gout exacerbations. You see the negatively birefringent crystals, and it'd be pretty bad thing. So that's thiazide diuretic. Next here is ACE inhibitors. So ACE inhibitors, basically, this all has to do with the renin-angiotensin-aldosterone system. What basically happens is the kidneys have cells that detect how much blood is in the body. Okay, how much pressure is going on these juxtaglomerular cells, and this whole system is involved, releases renin, and then the renin affects the angiotensin 1 to angiotensin 2, and then the angiotensin 2 goes throughout the whole body, and it activates, the effects of the aldosterone, and it causes vasoconstriction, so things tighten down, because the body thinks that it's losing blood here, right? Because it's not enough blood is getting to the juxtaglomerular apparatus. And so the whole effect here is hypertension. If you have increased effects of aldosterone, remember, it holds on to sodium and also water. if you have more aldosterone and you have vasoconstriction from the angiotensin II, then the person's going to get hypertension. And so an ACE inhibitor is an angiotensin converting enzyme inhibitor. And so what it does is it prevents angiotensin I from turning into angiotensin II. And that is good, because then angiotensin II can't go around raising your blood pressure by affecting the aldosterone and causing vasoconstriction. And there's another effect too with this, which is the one that they like, which is it prevents the breakdown of bradykinin, and that bradykinin then is able to cause vasoconstriction, because they found that the bradykinin works that way. Therefore, ACE inhibitors are great, and they're good for kidney disease because of the bradykinin effect on the efferent arteriole, and however, you do not use them in pregnant women because they are teratogenic to the baby. You also need to be careful if a person's taking and all of a sudden start developing a dry cough, and they have angioedema. Okay, so basically they start swelling around their lips and whatnot. Then you need to start worrying that they're having an effect from this. And my understanding, I don't remember exactly, but basically there's pathways, and because the bradykinin isn't being broken down, I believe what's happening is that it increases, basically the body starts shunting over to the leukotriene pathway, and then the leukotrienes can cause inflammation. So if the person has chronic obstructive pulmonary disease or asthma, and you give them, oh, you know what, I'm getting this confused, sorry, with beta blockers. Stop there, erase that last part. Oops. Okay, hold on there. So anyway, but it can cause angioedema. We'll stop there. I'll talk about that in beta blocker. Okay, so next here is the ARBs, a similar thing. All the ARB medications ends in sartan, like candesartan and lobosartan and all these different names like that, all end in sartan. And rather than preventing the enzyme that turns it from angiotensin I into angiotensin II, this just goes straight to the receptors, and it just blocks the receptor, okay? And so that way, you know, they still have angiotensin II in the body, but it can't do much because the receptor is blocked. So that also works similar way. Next, calcium channel blockers. You can understand smooth muscle, like in the heart and also in the blood vessels, works by these calcium channels. Okay, so the calciums come in, it causes constriction, muscle contraction, and so if you have a medication that prevents the the calcium channels, basically blocks them, prevents calcium from going in there, then they can't contract. So what do? They relax. And also the heart is going to slow down a little bit and kind of relax. And ultimate effect is that it decreases blood pressure. Beta blockers, so you have, that was kind of the thing I was talking about earlier, but I was trying to speeding up a little bit here. Basically, it slows down the heart a bit. And but this is the one I was telling you about earlier, contraindicated in COPD and asthma because of that pathway effect. Basically, beta blockers, the way they work, won't go to similar to albuterol, except for the opposite, and that can be dangerous. So, okay, next here is methyl-dopa, and methyl-dopa is a central alpha-2 agonist, so it basically decreases your sympathetic response. That is good because what does the sympathetic system do? Sympathetic nervous system causes your blood to, your heart to beat faster, which is going to increase your cardiac output, which is going to raise your blood pressure, especially systolic, and it also causes your blood vessels to contract, which is also going to raise blood pressure. So you don't want that. So that helps block that. Remember, methyl-dopa is the drug that you use in pregnancy, hypertension of pregnancy. Okay, next here is nitroprusside. So nitroprusside relaxes the arteries. It causes profound blood vessel relaxation. So it decreases both afterload and preload. Most of the other ones decrease just afterload, but this one decreases both because it has a really big effect actually on the veins. They get much larger, and the blood pressure can drop really rapidly. Then here we have the potassium-sparing diuretics, and their effect here is this is like aldosterone blocker. These drugs are easy to remember too because they sound similar to aldosterone. The spironolactone, the end of the "one," and their effect is to block the effects of aldosterone, and so the person is going to not not hold on to the sodium and the they are going to instead keep the potassium. So they call them potassium sparing, because most of the other diuretics can affect the potassium. This is potassium sparing. And then of course you've got the loop diuretics. Remember, loops lose calcium, and so they're good for edema, but they have some negative effects there. Okay, so now some osteopathic stuff. Just remember, T1 through 6 is what innervates sympathetic for the heart. T10 through 11 is for the kidneys. Seems like most of the solutions they had here for sympathetic facilitation with the heart and kidneys was rib raising, so remember that. And remember that pain, stress, and fear also increase blood pressure. You know, things like white coat hypertension. So why do you want to reduce the hypertension? Well, lots of reasons here: myocardial infarction, chronic renal failure, cerebrovascular accident, Binswanger's dimension, which is where basically the blood vessels in the brain become narrowed, from the hypertension. Hypertensive encephalopathy, microangiopathic anemia, aortic dissection, Barry aneurysms of the brain, aortic regurgitation, we talked about earlier. But that's the main one here I'm going to talk about next, though, is the myocardial infarction. So myocardial infarction is basically where not enough blood is getting to your heart, and your heart infarcts, or it becomes ischemic. And they call this coronary artery disease for obvious reasons. They call it coronary heart disease, and they call it ischemic heart disease. Ischemic meaning ischemia, not getting enough blood. Okay, so they break this up into 4 basic categories: stable, unstable, MI, and Prinz-Metals. And then there's 2 subdivisions on MI, the subendocardial or the NSTEMI, and then the STEMI. Okay, so let's talk about each one of these really briefly. So actually I'm going to go back to this picture again. The stable angina. Okay, stable angina. What does this mean? See this blood vessel here? It means that it's exactly what we see in this picture. Blood can get through, okay? And as long as the heart doesn't have to work too hard and doesn't have too high of oxygen and blood demands, you'll be just fine. But if you were to do something strenuous, this hole is kind of small. See that small hole on there? Because that hole is small, not that much blood is going to be able to get through. And so the demand can be higher than the supply when you do something strenuous, and they will feel angina or pain every time that they do something strenuous. And as soon as they stop doing something strenuous, or they take nitroglycerin, which opens up those blood vessels, the pain will go away. So they call it stable because they're stable as long as they relax and they're fine. Now, unstable is where it is blocked off. But the thing is that it's temporarily blocked off for a little while. Usually the pain lasting less than 30 minutes. It's enough to cause some enzyme, cardiac enzyme release, creatinine kinase, CKMB, can be a little bit elevated. Not too elevated, it depends on how much damage, but a little bit of elevation there. Not enough to cause troponin damage, where the actual myocardial cells are breaking apart and the inner structures of those are being released into the blood, but enough to release some enzymes, the CKMB. And so in this and in stable angina, you will see some ST depression. So the ST segment, if you remember on an EKG, there's the segment from S to T, and that will be right at the very end of the the QRS complex, and that will be depressed. It'll be a little lower. Now, why is it lower? Well, it's kind of it's having a hard time. It's suffering. It's not getting enough oxygen and blood, and so it's having a hard time recovering after the QRS. And so in the advent of an unstable angina, it just happens at rest. They don't have to do anything strenuous at all. They just be sitting there, and all of a sudden their chest hurts. But then it feels better. So the real difference between unstable angina and an angina are two things. Unstable angina occurs at rest, and nitroglycerin doesn't help it. Okay, so rest or nitroglycerin doesn't help it. And then the second difference here is that unstable angina does cause enough damage to release some cardiac enzymes, CKMB. So that's kind of the difference between stable and unstable. And then, of course, this is because of a complete blockage, though temporary, versus a partial blockage. Now, if there is a full blockage that stays, then we call this a myocardial infarction. This is where actual heart tissue, heart muscles die, and troponin is released. Okay, so there are 2 types here. There's subendocardial, and then there's transmural. Transmural means it's all the way through. This is the killer. Okay, all the way through, from the inside to the outside, the entire muscle is going to die. Okay, and of course this can later rupture and cause cardiac tamponade and all these problems. So this is a bad deal. And they call this, they compare these. They call it end-STEMI and they call it STEMI. Okay, so subendocardial, which is just the top part or the end part, whatever, not all the way through. They call that a subendocardial, and it is an end-STEMI. And it's called end-STEMI because it's called a non-STEMI. Now, what does STEMI stand for? This means non-ST elevation myocardial infarction. In other words, the ST segment is not elevated, whereas in a transmural, anything that goes all the way through or affects the whole thing does cause ST elevation. Okay, so the transmural, which is worse, is called a STEMI, ST elevation myocardial infarction. Now, there is something else that actually does cause ST elevation signs, but doesn't result in heart death. And you're like, what the heck, what could that be? Well, sometimes these blood vessels in the heart can just kind of freak out. They have a spasm, and with the spasm, they clamp shut. No blood gets to the heart for a little while. The person feels like they're having a heart attack, and it looks like they're having a STEMI, but then it gets better all of a sudden, and it gets better with nitroglycerin. And this was called a Prinzmetal's angina, okay? So there are only, if you want to sort this out a little bit, let's go to this next slide here. This is basically everything that I've been talking about. But if you want to sort this out a little bit, you can ask yourself, okay, is there ST elevation as opposed to depression? Okay, if there is ST elevation, then it has to be either a Prinzmetal's or a STEMI. Okay, those are the only two that have elevation. All the other ones are ST depression, and they all have ST depression. Then the next question you ask is there troponin? Because only two have troponin, and it isn't the same as the other two. The only two that have troponin are the two where there's actual heart damage occurring, and that's the subendocardial or the end-STEMI, and the transmural or the STEMI. And so that will sort through most of them, and then if you just understand what's going on, you should be able to sort through the rest. It's pretty straightforward. Okay, so what do you do for treatment for coronary artery disease? Well, first of all, you got to ask the question, is there chest pain? Does the person have chest pain? Yes. Okay, they've got chest pain. Well, did the chest pain go away when they relaxed or you gave them nitroglycerin? If it did, well, then you're done right there. They had a stable angina. Okay, so you're going to treat that long term, the number of different things you can do for that. So what if it didn't get better? It kept it kept hurting after they're resting, and nitroglycerin didn't work, and it lasted for almost 30 minutes, and then it got better spontaneously. Well, that could be a stable angina. Okay, if you gave nitroglycerin and it gets better, it's going to be either a Prinzmetal's or it's going to be stable. But if it doesn't get better, it is a unstable angina, or it could be a myocardial infarction. Well, let's sort out the next part here. So let's look at the EKG. So we put an EKG on, and oh my gosh, there is ST segment depression. So if there's ST segment depression, now we know that it is not ST segment elevation, which means we know it's not a STEMI and it's not a Prinzmetal's. We know it has to be either stable, unstable, or N-STEMI, which is the subendocardial. Okay, so that's what that tells us. So the EKG really helps us rule this out. Well, let's look at the CKMB. What is CKMB going to be elevated on? It's going to be not elevated on stable, but it will be elevated on basically everything else. Okay, so and then troponin, what will troponin be elevated on? It will be elevated on a STEMI and an N-STEMI. So you can really rule this out here with those three tests and determine whether it's stable, unstable Prinzmetal's, or N-STEMI or STEMI. And now what do you do in the acute setting? So somebody comes in, oh, I'm hurting, my chest hurts. Well, but typically, a lot of times they'll have nitroglycerin on hand, and you can tell them, if your chest starts hurting, you can take this nitroglycerin, you can take it 3 times every 5 minutes. Okay, so that's quite a bit. And if that doesn't work, if they're taking this, up to 3 times every 5 minutes and it's not working, they're not having a Prinzmetal's or a stable angina. They're having an unstable angina or they're having an MI. And in that case, this person's going to need 325 milligrams of aspirin, they're going to need oxygen, they might be in so much pain they need morphine. You're going to need to give them IV nitroglycerin, you're going to need to give them beta blockers, you're going to need to give them heparin, or you could instead give low molecular weight heparin, or instead you could give them fondaparinux, which is prevents or breaks down clots. That's what you can give them acutely, okay? And there's this acronym MONA-BASH that you can use, morphine, oxygen, nitroglycerin, aspirin, beta blockers, ACE inhibitors, I can't remember that. Statin medication and heparin. Okay, so yeah, those are all the things you want to give there. But chronic here, what do you want to give chronic? You want to give isosorbide dinitrate, and that's in the case of the stable, or even maybe an unstable. And then you want to give calcium channel blockers, especially for Prinz metals, and beta blockers. Aspirin is a good thing to be taking. Statins, what is statins? Statins are HMG-CoA reductase inhibitors. Basically what they do is they raise your HDL, they lower your LDL, okay? And a whole other lecture about how much to give and what to give. Just remember atorvastatin and rosuvastatin are the high potency HMG-CoA reductase inhibitor statins, and in that case it can lower it up to 50% of their LDL and get it down to an acceptable level. And then, of course, always the lifestyle changes for chronic use. You're going to tell them to basically follow the DASH diet, modified for what they're able to do. Eat healthy, live healthy, avoid sodium. And next we have ACE inhibitors. So ACE inhibitors are what we talked about earlier. They're really good, though, if a person's had a myocardial infarction, because it helps prevent myocardial remodeling. Okay, sometimes when the heart gets damaged, it gets scarred, it can build up all this scar tissue and all this muscle tissue in weird places, and it can do weird things, and that can be really bad, because then the nerves that are going through the heart can have a hard time conducting properly, and the person can get an arrhythmia, and they can die from that. So that's dangerous. So ACE inhibitors are really good. Another one good is ARBs. Second line, let's say you did all that stuff. You gave them the calcium channel blockers and the beta blockers and the aspirin and the statins and the lifestyle changes, and you did it all, and they're still just really hurting, okay? Well, you're going to do some other diagnostic exams. You're going to do, see what's exactly happening in their heart, but you may do a percutaneous PTCA. Anyway, basically what it is you go in there and you open things up, and if you put a stent in, it's even better, and it's even better still if you use a G2B3A inhibitor, and that'll help prevent the emboli and whatnot. So you can do that. That's second line, and if they meet certain criteria, like for example, let's say that doesn't work, or they have diabetes, or they have 70% stenosis of the LAD and left circumflex, or they have a 3-vessel disease, blockage, or they have the cardiogenic shock, or they have just terrible angina, pain that won't go away, unremitting. In those kind of circumstances, you can do a CABG, and CABG is a little bit more of a dangerous procedure, coronary artery bypass graft, and this is like opening things up here. It's a more dangerous procedure, but it seems to work better, which is good. And now lastly here, this is probably the most complicated part of the whole thing. It's something that I've really struggled with until I found out what it actually meant, and then all of a sudden it was so much easier. Okay, so you can look on a EKG and you can see all these weird squiggly lines, and they'll say, oh, they have an elevation in V1 through V3, and therefore, what do they have? Do they have a right coronary artery, or left anterior descending, or is it LCA, or is it left circumflex, or where is it? And you're like, what the heck are they talking about? Well, it turns out that really all this is talking about is these leads represent different angles of the heart. So you've got V1 kind of coming straight at you, V1, V2, V3, V4, V5, and V6. Now this is like anterior, posterior axis kind of thing for these ones anyways. And then from the bottom, you've got, 2, 3, AVF going straight from the bottom, and then you've got AVL and AVR coming up at the top here, and then you've got 1 coming across right at the side, okay? So you can look at where these things are pointing, what blood vessels these are pointing to, and you can find out what's happening in the heart. So V1 through 3 is anterior septal. So 1, 2, 3, right here in the middle septum. Well, what blood vessel runs right through there? Well, the right coronary artery runs right through there, and the left anterior descending runs right through there. So V1, 2, 3, RCA and LAD. Bam! Got it down. What about LAD? Okay, well, 2 and 3 point right at LAD. So if it's 2 and 3, then you got LAD. Well, what if it's 4, 5, and 6? Let's see, 4, 5, and 6. They all seem to point at LCA. Wow, boom, right there. And what about just 5 and 6? Well, 5 and 6 point right at left circumflex. Boom, right there. So if you just look at this, you can get it down. Now, what if, though, it's 2, 3, and AVF? Well, 2, 3, and AVF, they point right at RCA. Boom, easy peasy. I mean, this is just really makes it a lot easier. So if you just remember RCA, LAD, LCA, LCX, and you just remember DAX, or DAX, so RCA, DAX, and then RCA is on the bottom too, and then you just draw this out on a little heart, V1, V2, V3, V4, V5, V6, easy, 2, 3, AVF, easy, you got it down. Now, what if it's on a blood vessel on the back of the heart? Now, that's a little trickier. See back here, these dotted ones. So there's some back there on the back. And, the right coronary artery and the PDA. This is going to be kind of more complicated. So in this case, you want to look rather for elevations, you look for depression, okay? So depression and tall R waves can tell you that it's in the back there. So right, straight, 1, 2, 3, but in the back, look for the depression and the tall R waves. And that is all. I hope that was helpful for you.